it's an opportunity where women can say, you know what, I don't have hot flashes, night sweats, but I saw my mom, my sister, my aunt suffer from a fracture or, again, have really bad kyphosis and become more and more frail, etc. Osteoporosis is a terrible disease. Terrible. Once a woman has a hip fracture, 20% of the time she'll die within the year, and the rest of the time she's going to limit her activity and not be social again in most examples. So we want to prevent that as much as possible and keep women healthy and functional lifelong. So the short answer is all women are candidates. It's definitely a nuanced conversation with your doctor. It requires a doctor that understands hormone therapies and is open to hormone therapies. I think more doctors are realizing this is an area they need to look at. But right now, we don't have the physician capacity that has the right expertise to really do a lot of this work.
Hope you enjoy a preview of this full episode published exclusively as a bonus for our incredible online NeuroNerd community. This group is the backbone that keeps this podcast thriving, and you can find out more at therapistuncensored.com/join.
Hey, you guys, while we know relationships are wonderful, they are also really hard. Many of us believe that they shouldn't be, that if we have good connection and good communication, things will just go smoothly. But it's really that belief that can make us feel stubborn and even more hopeless. So relationships take work. It does for Sue and I. We can make it look easy. It's not. And one of the ways is because many of us, we differ. We differ in what activates us, what makes us feel threat, the expectation, and it's these differences that are held in our body, not our thoughts. And they influence how we talk, how we love, how we fight. So holding that belief, if he or she or they could just understand me, if they love me, they do something different, is not really true. And we're talking about relationships with your partner, your teenager, your mother-in-law. So Sue and I have created an online course that can help you understand yourself and those you love in a different way. This is not just for therapists, it's for everyone. Although the good news is if you're a therapist, you can get CEs along the way, and all of you can use the visuals and the worksheets individually, or you can even use them in your own private practice. So while the course is based on our book, Secure Relating, Holding Your Own in an Insecure World, it is definitely not a replication of the book. We talk directly to you. You learn how to understand more deeply your attachment, those you love, the neuroscience behind it, and how to build secure types of connections right now in your everyday relationships. Rather than changing one another, y'all can shift together in very important ways. It's very powerful. We're getting great reviews. Check it out. It's at therapistuncensored.com/BAS. Therapistuncensored.com/BAS. The BAS stands for Beyond Attachment Styles, the Science of Growing Secure Adult Relationships. And by the way, the cost of the course is about the amount of one individual therapy session, and yet you get hours and hours and hours of what we think is extremely valuable information. So check it out.
Hey, everybody. Welcome back to Therapist Uncensored. Today's conversation is for anybody who has a vagina or cares about the health of said vaginas. Women's sexual health has been so pushed aside that we often don't even know what we don't know. We are often dismissed, rushed, simply, again, like I'm saying, don't know what to ask. And I can almost guarantee that everybody listening today is going to have one of those light bulb of insight moments that feels so good. Dr. Christine Vaccaro is double board certified urogynecologist and sexual medicine specialist with over 20 years of practice. She's also a retired colonel in the U.S. Army. She's part of a small but growing movement of physicians treating women's sexual health as the serious, complex, and utterly treatable medical territory that it is. We're going to get into hormones, anatomy, pain, pleasure, and the interplay between psychology, medicine, and sexual function. So welcome to Therapist Uncensored.
Thank you, Sue. That was a lovely intro. I can't wait to see where this conversation goes.
Well, why don't we start with what I said last about this interplay? So often therapists and physicians don't directly speak to each other, or at least not often enough. And so I'm curious, what would you say from a medicine standpoint that therapists should know? And also, where's your wish where that you can okay, this I want to hand over to you guys?
Yes, I love this question. I'm an osteopathic physician, by the way, which is a little bit different than allopathic medicine. I really feel like I, in medical school, got to bring in the whole person, the holistic approach. Like that was very fortuitous because what I do right now is all holistic, right? Taking into account the whole woman, her mental health and her physical health. So to your question, I really love a multidisciplinary team. Like it takes a lot of people to treat the full person, and I am not trained in therapy, just like you're not trained in surgery, like what I do. But we can work together to collaborate to help the whole person. So I oftentimes am actually speaking with our therapists because we actually have wonderful relationships with our local therapists. A lot of them are sex therapists. A lot of them are general therapists. It really depends on what the woman needs. We also have the luxury of taking a lot of time with our patients. So I do delve deeply into the weeds of what else could be going on with the woman's X, Y, and Z. We'll just use libido as a starting point because oftentimes it is hormones. Oftentimes it is adverse drug effects, but oftentimes it is cultural shame. It's religious trauma. It's medical trauma. It's sexual trauma, right? There's so many traumas that we need to address to make sure we can actually put all the pieces together and direct the patient in the right avenue so she can actually get better.
Well, and that makes me think, can you say a little bit more about where you're located and anything else you want to add about yourself so that people can orient?
So you did a great job at the intro, but I've been practicing physician since 2003. I went to medical school in Texas and then was in the military for 30 years. I retired about a year ago. My last duty station was Walter Reed National Military Medical Center, which is the largest training center for the military, and I was in charge of the fellowship for urogynecology. So I love being in academic medicine, but now, after I've retired from the military, I'm in a concierge practice in Bethesda, Maryland, which I get to do full scope gynecology as well as urogynecology, which is pelvic floor disorders like urinary leakage, bowel leakage, vaginal support issues, sexual pain. And then I also get to do sexual medicine, which is disorders of libido, arousal, orgasm, and other hormone therapies and other pain disorders. So I sort of collectively put that in the bucket of quality of life women's healthcare.
So many questions.
We can go so many different ways.
I know. So you said something about we'll start with libido.
Mm-hmm.
So let's start with libido. I almost want you to just talk to me and all of the folks that are listening, what are the things that we need to be asking that we're not aware of that should be on our radar?
And when you say we, you mean therapists or do you mean patients?
I mean patients.
Perfect. So I think patients don't even realize that there are treatments for low libido, right? I think oftentimes women aren't asked in medical appointments for that, any appointment, right? We just don't validate a lot of times women's sexual health. So low libido is decreased sexual thoughts and fantasies that is causing personal distress for more than 6 months. That's the official definition.
So it's a decrease. You've had it and you've lost it.
Correct.
It's not that your partner wants more sex than you do.
Oh my gosh, that's such a good point. Partner mismatch isn't low libido. That's just like, I want eggs and you want bacon. Like, it's just we have different wants. It is not low libido. However, partner mismatch can become a distressing problem, obviously, but that's not the definition of low libido. That's partner mismatch. So that was an excellent question. And going back to what you asked, like what should patients ask for? Again, number one, there's just the awareness that they can ask, right? That their sexual health is important to ask about. I think oftentimes in medicine, we only ask about sexual pain, right? That's the only thing that we validate. Like, oh, do you have pain? Oh, does it hurt? Oh, lubes and creams and all sorts of things we can do to treat that medically. But we don't often ask about like, how's your libido? How are you feeling? Have you had decreased thoughts and fantasies? Do you still have responsive desire? Did you lose your spontaneous desire? If so, at what point? And what medications were you taking and what was happening in your life? So there's so many things to dig into with that question. And oftentimes most medical centers aren't set up with enough time to get into that, which is why therapists are wonderful because generally you guys get to have time and talk to patients and get to know them really well and understand the psychosocial aspects that sometimes in medicine we don't get to because there's not enough time. Unfortunately, again, I don't want to go down the rabbit hole of insurance, but education isn't well coded or reimbursed. So most doctors don't have time for education and training because that doesn't get reimbursed well. We're in a practice that we use a different model, so we have plenty of time, but that's not the typical thing. So sometimes as a patient, you have to go in with questions written down like, hey, I started this X, Y, and Z medication, let's just call it Prozac, and all of a sudden my libido and orgasm are gone. Like just really simple, basic things. Like I took this medication and now I'm having this medication side effect that's influencing me sexually, and I want to have a chat about it. So sometimes you just have to have things written down and ready to go for the clinician to be able to guide the conversation. Oftentimes, though, it's a little bit more like, you're kind of like slowly falling down a mountain, like really slowly. Like 20 years ago, I had great libido. I didn't have to think about anything and everything just worked. And now it's like, I really have to work at it. I really have to get my mind in the right headspace, et cetera, et cetera. And oftentimes that can be just from declining hormones, especially testosterone, which I hope we can delve into, because that one in men and women just slowly goes down over time. It does not fall off the cliff like menopause. In menopause, estrogen and progesterone sort of fall off the cliff, but testosterone's still there. It's just slowly declining. So it really depends on the patient and the history, but having a little bit of history going into the appointment and really making the appointment, if libido is the issue, the primary thing you talk about. Oftentimes what I've seen is women come in with, let's just say, oh, I need a well woman exam, but really they don't really want a well woman exam. They really want to talk about libido. But on the chart, it says well woman exam. So the doctor spends the whole time doing this, that, and whatever for well woman checks, which, by the way, sexual health is not generally on a well woman check. And then as the doctor's leaving with the hand on the door, the woman's like, oh, wait, we didn't talk about libido because that's what I actually really want to talk about, because we don't validate oftentimes that aspect of the medical history. So chief complaint, low libido. Like, don't be afraid to have that as the chief complaint.
Oh, that's a great suggestion. And you mentioned gender equity before we got on. Do you have ideas about why something like this isn't in a well woman's check? And then this is also just a launch into anything you want to say about gender equity.
This is a very long conversation, but right now in medicine, we don't give equal time and attention and resources to women's sexual health. And I could illustrate a million different ways, but the clitoris just became a structure that we taught about 20 years ago, and the full anatomy wasn't even published until 2005. Just sexual anatomy we haven't given equal time and attention to, as well as sexual health complaints. So again, like I said, if women aren't complaining of pain, then everything must be fine, right? As a gynecologist, I was taught to examine the vulva, right, the external genitalia, but don't touch the clitoris and don't examine it because that might make the woman feel uncomfortable, right? So we never were, even as clinicians, given permission to examine that body part, which I find is a really important body part, worthy of examination, but we don't teach doctors that that's okay. And women aren't told anything about their clitoris. So I often use the analogy about men that don't have a circumcision, right? They're given a lot of instruction about how to care for their foreskin, how to care for their glands, all this instruction. We don't even tell women they have a clitoris, let alone where it is or what to do with it. And we oftentimes don't tell them how to care for it, which leads a lot of patients to my clinic having various issues with their clitoris, whether that's clitoral pain or decreased sensation, decreased arousability, decreased orgasm. So what I'm trying to just set up here, Sue, to answer your question is, we have a long way to go with equality in sexual health education. And I'm going to share this quick story because I think it'll get a laugh from your readers and your audience. I'm sorry. So I obviously talk about this a lot with my children, right? My children are now teens, but I'll never forget the day when my son's 5th grade teacher called me after their family life education week and told me that one of the female classmates asked, do girls have penises? And my son kind of sheepishly raises his hand, right, and says, well, my mom's a vagina doctor and says girls have a penis-like structure and it's called the clitoris, right? Anyway, like total proud mom moment here, right? But just to illustrate this, the teacher was so astounded. She was a mature teacher and had never been taught anything like that in her life, let alone by one of her students. And it just goes to show we have missed an opportunity to educate about female and male genitals equally, which then leads to equality and asking for other things. Pleasure, orgasm, right? There's a huge orgasm gap. Men orgasm a lot, women don't. We've just missed a huge gap here. And I think if we can educate more on female genital anatomy and close that orgasm gap, the pleasure gap, we can eventually, maybe one day, get a little bit closer to gender equity. So that's kind of what I talk about a lot because I'm passionate about it.
Thanks for listening to this preview of bonus content. If you would like to continue with the episode or to support free worldwide access to important material like this, you can join our online community for as little as $5 a month at therapistuncensored.com/join. Thanks.